Good morning. I'm here today to speak about managing common complications of tube feedings. My name's Mary. I've been a dietitian for about 30 years. I've been working with Shield Healthcare and primarily, specifically with those patients on home tube feeding for about 10 years now. It's become a tremendous passion of mine, and I am very excited and honored to be presenting here today at Oley. So next slide, please. So some of our objectives today and what we're going to spend about the next 20 or 30 minutes on are talking about really what can go wrong when you're at home with the tube feeding. And we'll start with some quick statistics from Aspen. Then we'll talk about what some of the common complications are. And then lastly, we'll discuss how to manage and prevent these issues. Next slide, please. 50,000, wow, that's a big number. That's the number of patients who go home on tube feeding each year just in the United States, according to a study conducted by Aspen and published in 2017. So just to give you a frame of reference for some of the things that we'll be talking about, I want to just kind of talk about who are these patients or what type of feedings are they going to have? And you can see from the graphs here that they are overwhelmingly primarily G-tube fed. Smaller proportion GJ, even smaller J tube, and then about the same amount, 8% of NG or NJ tubes. And the administration type is primarily bolus via gravity or syringe, and then patients using pump comprise of the other percentages. Next slide, please. And why should we talk about managing home tube feeding complications? It's important. It's really important. One study showed that almost a quarter of the patients discharged home went back into the hospital within the first 6 months because of problems related to their tube feeding. So I'd like to stop and kind of pause on that. So 25% of patients that were discharged home on a tube feeding were readmitted specifically related to a problem with their tube feeding. What percentage of those readmissions could have been avoided? We don't really know, probably a fair amount of them. So that's what we're here to do, is to kind of try to talk through some of these things that can be prevented or solved at home. Then there's malnutrition. When you don't get enough nutrition because of problems related to your tube feeding, the risk of malnutrition increases. Malnutrition makes you more prone to infection, delayed wound healing, and other issues that could land you back in the hospital. And we also, of course, one of the main goals of Oley is to improve the quality of life. In one study, over 60% of the people on tube feeding at home had problems like nausea, vomiting, diarrhea, and constipation. Next slide, please. So here are some of the common complications that we'll touch on today. I've broken it up into gastrointestinal or gut related, and then the other kind of side of the coin would be the tube related or the mechanical complications. And as a bonus, because we all love to talk about ENFit, we'll be talking about enteral misconnections, which are a less common complication of home tube feedings, but one can result in serious injury or even death. And please note, I am speaking about ENFit today, not a lot, but do note, please, that there is an entire presentation on it tomorrow. Next slide, please. So one of the main complications, one of the biggest problems that we have, especially with patients right away when they're getting a tube feeding, right when they're getting home, perhaps they haven't eaten for a while, their gut's just really sensitive, is nausea and vomiting. It's kind of the knee jerk to blame it on the formula. What we found through trial and error and years of experience is that it generally isn't the formula. So some of the things that we want to look at are, if you experience nausea, usually it's the rate of the feed that maybe is going to be one of the main culprits, and slowing down the rate may help. If you're syringe feeding, what that can mean is giving only a quarter or half of a can at a time, and perhaps even waiting a few minutes in between those kind of boluses that you're giving. You can also try lowering the syringe closer to your stomach to help slow down the rate of the flow. Just always remember that the higher the syringe is above your body, the faster the formula will flow in by gravity. If you're using a gravity bag to feed, you can slow the rate by closing or adjusting that roller clamp that pinches the tubing so that the formula is allowed to slow down. And then with a feeding pump, of course, we have many different ways that we can control the rate there. We adjust the numbers on the screen. We can lower the rate by half and see how that feels. And if you feel better, then slowly increase the rate to a point where you can feed without nausea. Really important, if you ever experience vomiting, stop the doctor and call your doctor stop the feeding and call your doctor immediately. And let your doctor know, of course, if you can't tolerate your formula at the recommended rate, you may need to change your feeding regimen to get all of your nutrition in. There's many different ways to feed, many different feeding regimens. One size does not fit all, and something that you tolerated in the past, you may not be able to tolerate now. So it's important to not just kind of bear through that and know that there's ways that feedings can be adjusted so that it can be tolerated and you can get the nutrition that you need. Next slide, please. So another one, a big one, is it constipation? Is that causing the nausea and vomiting? So we should always consider when your last bowel movement was, and constipation may be suspected if you haven't had a bowel movement in some time, or you're having them less than 3 times a week, or if you're having pain or difficulty passing hard, dry stools. A change in your usual bowel habits may also indicate constipation. Next slide, please. So is the tube in the right place? That's something that maybe we don't think of right away, but this is of vital importance, as you can imagine. If the tip of your feeding tube has moved outside of its place inside of your stomach, it can cause stomach irritation and nausea. So pay attention to the markings on your tube feeding, on the tube, and how far the external bolster is from your skin. There should be about the width of a dime in between that hard external bolster and your skin. And if your tube has a button, you should check the amount of water that's in that balloon. I'm sorry, if your tube has a balloon, you should check that amount of water in the balloon on a regular basis to make sure that that balloon is still intact. Next slide, please. So more tips to kind of try to conquer this very common complication of tube feeding is make sure that you're sitting up or the head of the bed is elevated during and for at least 30 minutes after you're feeding. Make sure that you're not using cold formula. Don't pull it right out of the fridge. Cold formula sometimes can cause stomach upset, so you may want to let it warm up to room temperature before using it. Another complicated one, or something that happens sometimes, is that your feeding regimen may be to give your bolus of feeding in addition to water at the same time. So it could be, something like 120 mLs of water before and after your feeding, and then a can of formula. That's a lot of liquid into your system all at once, and sometimes that can cause a little bit of GI upset. So it may be better for you to actually separate the feedings a bit from the water flushes so that you're not getting quite such a large load of fluid all at once. Also, additionally, be sure that you're priming the extension set and the pump set before the feeding to prevent pushing air into the stomach. And then if we've gone through all of these, so you've slowed down the rate, you've maybe reduced the quantity, you've separated the water out from the formula. So we're kind of trying everything. If all else fails, then perhaps this is the time to trial a different formula. Next slide, please. But is it the tube feeding? Or is it diarrhea? This is an important one. It's kind of important to talk about really what is diarrhea. So diarrhea is going to be large watery stools. If you get all your nutrition from a tube feeding, remember that your bowel movements may not look the same as they did perhaps when you were eating regular table food, but you shouldn't have large watery stools. Loose stools may be the result of too much formula too fast, and the solution may be just to slow it down like we talked about earlier. Additionally, if you slow down your feeding, we may need to feed for a longer period of time to get in all the formula that's prescribed. Let your healthcare team know if you make any changes to your feeding. That's really important. And if slowing down your feeding doesn't help, it may be something else. Your doctor or dietitian may try a formula with nutrients that are already broken down, or one that doesn't contain common allergens such as milk, soy, eggs, wheat, or nuts. Next slide, please. So it could be an infection as well, that diarrhea. So especially if you've been on antibiotics in the past few months, or if you've been hospitalized in the past few months, we may want to test for this. And it's especially important if you've had a gastrointestinal infection in the recent past. Next slide, please. Some medication can cause loose stools as well. The very common culprits are antibiotics, laxatives, promotility agents such as Reglan, and liquid medications containing sorbitol. Chat with your doctor or pharmacist about this. They can help you determine if any of them are contributing to the problem. And if you are taking liquid medications, it's a good idea to typically dilute them with water to decrease the chance of them causing loose stools. Next slide, please. Ask your doctor about whether maybe perhaps you should start taking a probiotic supplement. Probiotics are live bacteria that provide health benefits, and certain strains have been shown to be effective in preventing the diarrhea that's associated with antibiotic use. It may be helpful to try a formula that contains fiber. Insoluble fiber adds bulk to stools and supports the good bacteria in your colon. And certain types of fiber called prebiotics are food for the good bacteria in your colon. When they process the prebiotics, they help to inhibit the disease-causing bacteria, promote the absorption of water from the colon to make stools more formed, and provide the energy for your cells in your intestine. Some formulas do contain these prebiotics, and one example of that would be the agave inulin. So if you're having diarrhea, you want to minimize your risk of becoming dehydrated. Continue your tube feeding at the rate that you can tolerate, and continue to give yourself water through the tube. If you're unable to tolerate the formula and water, please tell your doctor immediately. Next slide, please. Constipation is actually more common than diarrhea in people who are tube fed at home. If you're constipated, the first thing you should consider is whether you're getting enough water. Your tube feeding formula contains some water, but it may not be enough to meet your needs. I see this very commonly. Patients are discharged home with a formula regimen, but without a free water regimen. Somebody may need up to an additional liter or so of fluid a day outside of the water that they're getting within the tube feeding. So this is really important. And remember that some formulas contain more water than the others. You can see from the chart, a 1.0 or 1.2 calorie per ml formula has more water in it than a 1.5 or a 2 calorie per ml formula. And the water that you need depends on certain factors, including your age and clinical condition. And your doctor or dietitian can tell you how much additional water you should add to meet your needs. And adding water to your tube also helps to keep it clear and unclogged. And this is something that I go over many times. We flush the tube for two reasons. We flush the tube to ensure tube patency, and then we also need to flush the tube to ensure that we're getting enough water. And in a few minutes, we'll talk about how to use water to clear the clog if your tube becomes blocked, the bane of every tubie's existence. Next slide, please. So fiber, we all talk about this. So getting fiber can also help with the constipation. Fiber actually draws the water into your colon to make the stool softer. This also helps to add weight to the stool to move it through your colon faster. And fiber adds bulk to the stool. The extra bulk puts pressure on the wall of your colon, which can help speed things up. Formula without fiber is often associated with constipation. And ask your doctor or your dietitian if you're getting enough fiber. Next slide, please. So let's switch gears now a bit and talk more about going a little bit outside of the body and talk about complications that occur with skin around the feeding tube. And look at this beautiful stomacyte. This is what the skin around the feeding tube should look like. Not always, but should. Next slide, please. So leakage around the tube, what's going on there? So the skin may look more like this if there's leakage around the feeding tube, and leakage of the stomach fluids can occur if the tube fits too loosely. So we always want to check the external bolster or the balloon volume. To help with that, you can apply a skin protectant or moisture barrier, and then use a short-term dressing such as gauze to help absorb that drainage. Generally, if the G-tube site is clean and dry, we say you don't need gauze, don't use it. But if there's any moisture, anything that needs to be absorbed, that's the time to add gauze or some other device there, a fabric device, whatever works for you, makeup sponges to help absorb some of that moisture. Leakage of the stomach fluids again can occur if the tube just fits too loosely. It may need resizing as well. And this may be also because the external bolster has moved up the tube or the balloon doesn't have the right amount of water. So those are kind of our problem solving with the leakage. Be sure that you have the right size tube, that the bolster's in the correct place, and that the balloon is filled to the correct amount of water. Next slide, please. Ouch, this one always makes me say ouch. So pressure necrosis, is the tube too tight? On the flip side, if the tube is too tight against your skin, the pressure can cause damage to the skin. And you may notice redness, irritation, and pain around the tube. You can see that this tube here has just been pulling on that site and causing some necrosis or damage to that area. You can see that the bolster also has been moved away. Next slide, please. Hypergranulation tissue is exceptionally commonplace. We see this a lot, and it may show up as discolored, irritated, or raised skin around the tube. You can help prevent it by only using mild soap and water for routine cleaning of the skin around the feeding tube. And you should also stabilize the tube so it doesn't move around too much. This occurs when there's kind of a constant rub from the device, the button or the G-tube against the skin, and the skin kind of builds up, our body builds up this additional tissue to help kind of make a little buffer there because it's being irritated. So to prevent the hypergranulation tissue, we want to try to remove that irritation. Some people do better with switching out a different brand of a low profile device or a different type of G-tube as well. Next slide, please. Bacterial yeast infections really usually come from the skin just being too moist. So how we treat this or how we prevent this is always to wash your hands before touching the skin and to clean the site daily and try to keep it dry. An infection may occur. So you may notice pain, inflammation, redness, drainage with an odor or a color. So again, what we really want to do is try to keep our hands clean anytime that we're giving a feeding or treating or cleaning around the tube site, and also try to keep that site around your tube as clean and dry as possible. Next slide, please. Regular care of the skin around your feeding tube should include all of these things, just as we've been talking about. Wash your hands, rotate the tube a quarter of a turn, not with J-tubes, however. Check your external bolster height, secure the tube so that it's not moving too much, and keep the area clean and dry. If you notice any or experience any skin issues around your tube, contact your doctor or nurse right away. Next slide, please. Ooh, here's a big one, clogged feeding tubes. This is a doozy. We talk a lot about prevention, and prevention is really where we want to start and encourage. And really the best ways to do that is just to flush with water. Flush very regularly with water every time you use the tube and every few hours when not in use. So how do you know that your tube is clogged? Well, things aren't going to go through. You may be trying to administer a medication or the formula. It just won't push through. You may run on the pump, and the pump is yelling at you, no flow out. What's happened is that your tube has become clogged with either dried medication or formula. So to prevent this is to flush on a very regular basis. Your doctor or your dietitian should be able to tell you how much water to use. But a good rule of thumb is to flush before and after every feeding. before and after every medication, and every few hours, even when the tube is not in use. We want to use water to flush your tube, other liquids such as juice and carbonated beverages, although I don't think they're as commonly used as they used to try to unclog a tube, can really possibly make that clog worse. So we want to, excuse me, just use water when flushing the tube. Next slide, please. So preventing the clogged tube, medications are the main reason that most tubes become clogged, but you can help prevent a clog by giving your medications separately from each other and by flushing after each one. As a general rule, avoid adding medication or really anything to the formula. Mixing the two can cause clumps in your formula, which may clog your tube. And review your medications with your doctor or pharmacist. Not all forms of medication should go down your feeding tube. Next slide, please. If you're unable to get the water or formula through your tube, first check to make sure that it's not clamped or kinked anywhere. Then try these steps to clear the clog. You may need to repeat them a few times. If you still can't clear it or use your feeding tube, notify your nurse or doctor. They may have other ways to unclear the clog, such as enzyme or mechanical devices. If the tube cannot be cleared, it may need to be replaced. Tube dislodgement. So managing and preventing for the tube dislodgement, to manage it, so if the tube does come out, what you want to do is replace the tube. Even if the button's burst or the balloon is burst, go ahead and put it back in and tape it down until you can have that replaced with an intact G tube. And to prevent that, mark the outside of the tube, check the external bolster, and check the balloon per your healthcare professional. Again, it's very important to keep the tube or tubing of similar size in until you can get the tube replaced, because the stoma can close in just a couple of hours. Next slide, please. Enteral misconnections occur when enteral devices, such as feeding tubes, are accidentally connected to non-enteral devices, such as IV lines, respiratory tubing, or urinary devices. For example, formula can be inadvertently infused into the veins through an IV line into a respiratory tubing. The FDA has received reports of deaths and injuries related to enteral misconnections, and it's thought, though, that many enteral misconnections don't get reported to the FDA. So I'm going to touch on this very quickly because, again, there will be an entire presentation tomorrow on ENFit, but I just do want to touch on it because it is a complication of tube feedings. So the best way that we want to prevent these enteral misconnections is to use feeding tubes, pump sets, and syringes that are physically incompatible with IV, respiratory, and other non-enteral devices. So what is that? What does that mean? I think we all know this word. ENFit is the brand name for the enteral connection that is physically incompatible with other non-enteral devices. Again, I'm going to save a lot of this for tomorrow. It'll be gone over in great detail by Vicki. I am happy to report that it seems like there seems to be an uptick in awareness and conversions to ENFit throughout the industry. I'm grateful for the manufacturers to get on board and to help promote this transition. So I see us really kind of starting to have an uptick in patients and facilities converting over to ENFit, which is gratifying to see. Next slide, please. You know, sometimes we still do have some patients that are home, perhaps on ENFit, or still home on Legacy, and the hospital is using ENFit or using Legacy, and the two kind of don't match. It's important that what you have at home all works together. So if there's an ENFit tube placed, you need to be sure that you have ENFit supplies at home. So what can you do? Contact your home medical supply company. Ask your hospital if they have ENFit supplies. If you're being admitted and you have an ENFit tube, but the hospital is still using Legacy, you may want to bring in your own supplies. And also learn more at stayconnected.org or Oley.org as well. You want to be sure that as you go between home and hospital, that your tube can be accessed and enteral misconnections are prevented. So my references, next slide. And I can open it up to any questions now.
Thanks so much, Mary. We do have several questions. The first one is, and maybe you can't answer it specifically, but maybe you can give a tip on how to determine the answer. But Jennifer asks if there's a standard amount of water or saline that should be in the balloon, and is it in the balloon of a low profile device? And is it different for different tube types and sizes?
Okay, yeah, I can answer that for sure. So no, it varies dependent on the size of the G tube. So each G tube should say on it, whether it's a low profile device, you would find it in the literature that came with it, or whether it's a regular G tube. It could be anywhere between 3 and 20 mLs that would go into that balloon. So it really is specific to the size of the G tube.
Thank you. Bethany's asking for a type of healing cream. If you have any suggestions for healing creams to use around the tube, in addition to calmoseptine, which she's already familiar with.
I do not. I don't know if there's anybody else on the panel that can jump in and I guess another question would be, what are we trying to heal? What is actually the issue? I'm sure that needs to be probably addressed by a physician to make sure that it's not a bacterial situation that perhaps might need a topical antibiotic, or whether it's hypergranulation that would need some silver nitrate. So it's a little hard to answer. I don't know if somebody else would want to jump in on that one.
That's a good point. I don't think we have anybody else on the call that has this expertise at this moment. But there is a conversation going on in chat where some people are making some different suggestions. Yeah. And Brian has a question, which I hear, this comes up every now and then, but I like his wording. He says, is there a group of the Pink Stoma Society members? I have never, ever been able to keep my stoma clear. So is it actually achievable?
Yes, it is achievable. It can be, I think it's just some patients, some people just have difficulty keeping it looking healthy and dry. And it just has to do more with not the skin integrity, but just kind of their own composition, and really nothing that's being done incorrectly. I think for some, it just is a kind of a constant battle that you have to try to keep manageable and not let it get out of hand, but perhaps it would never go away.
Thanks, that makes sense. I will do one more question, and I don't know if you're available to, I know you have a really busy day, but I just wondered if you have a chance to go on, and I don't know if you are that familiar with Zoom either. I know you don't usually use Zoom for your meetings, but if you can answer any of the questions in the Q&A written, that would be terrific. If not, we'll encourage people to maybe email or to look at some of the other resources on our website where some of these answers might be found. But one more, maybe two more. One is quick, I think. How often should a J tube be replaced?
That's really going to be up to the gastroenterologist and the IR team, I would say. My general feeling on that, and I'm not an interventional radiology expert, would be if just to leave it until there needs to be it changed, or perhaps at least once a year.
Great, thanks. And then the other question was about granulation. The Asher says, my son is connected 24/7 due to short gut. His surgeon said there's no way to prevent it when he's connected all the time, but do you have any tips that maybe they haven't tried? He said, we do have the tube stabilized, and his son is 2 years old with a low profile device.
I did have somebody, and I mentioned it briefly in my talk. I had, so for us ladies out there, there's round makeup sponges. I had somebody say that they had great success with those. They would cut a slit in them and put them around the G tube, and that really helped keep that buffer to keep the skin from being irritated. That's something you can try. If gauze isn't helping, then perhaps one of the fabric pads that you can put in that are easily available might be a better help.
Great. Well, thank you, Mary. I really appreciate your helping and jumping in to give this presentation. It was fabulous. And all those questions are just so important and critical. We really appreciate it.
Of course. Thank you very much for having me.
Thanks.